Episode 30, The Magic Effect, How One Athlete's HIV Diagnosis Changed Public Health Forever. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and provide practice questions. This is a direct quote from Magic Johnson. I think sometimes we think only gay people can get it. It's not going to happen to me. And here I am saying that it can happen to anybody, even me. Those were the words of Irving Magic Johnson on November 7, 1991. A press conference by one of the greatest basketball players of all time didn't just change the conversation around HIV, it literally saved lives. Magic Johnson publicly announced his HIV positive status after his virus was detected during a routine physical examination required for a life insurance policy. He was 32 years old and playing for the Los Angeles Lakers at the time. He immediately retired from professional basketball following the announcement. By 1991, Magic Johnson was one of the most famous athletes in America. He was a 5-time NBA champion, 3-time MVP of the National Basketball Association, and 12-time All-Star. He, Larry Bird, and Michael Jordan had transformed the NBA into the fastest growing sport in the country. And crucially, he was a widely known, beloved heterosexual man. When he announced his HIV diagnosis, it was front page news everywhere. It was a landmark moment in public health history for several reasons. It challenged the widespread misconception that HIV was confined to specific populations, particularly men who have sex with men and intravenous drug users, demonstrating that heterosexual transmission is a significant route of infection. It also dramatically increased the public awareness of HIV and AIDS and helped reduce stigma surrounding the disease. I'm Scott Hull, a primary care sports medicine physician, and I am studying for my sports medicine certification exam in 2026. I hope you'll join me on the journey. This podcast is for educational purposes only. While I usually go over a specific case study, I chose to discuss Magic Johnson's diagnosis because I'm going to be asked about questions related to HIV and athletic participation, and I identified another study to discuss in the context. The study I would like to discuss is Information Shocks and Celebrity Exposure, the Effect of Magic Johnson on AIDS Diagnosis and Mortality in the U.S. by Cardazzi, Martin, and Rodriguez. It was published in Health Economics in 2023. This team of economists published their study quantifying exactly what happened after the diagnosis of Magic Johnson. Using the 1991 National Health Interview Survey, they found that among people who had never been tested for HIV, the expectation of getting tested in the coming year jumped by 40% after the announcement. Using the CDC's AIDS Public Information Dataset, individual-level diagnosis records across major metropolitan areas, these economists tested whether the announcement actually changed outcomes. Their hypothesis was that heterosexual men, the group most likely to have underestimated their risk, would show the biggest response, especially in cities with NBA teams, where regional broadcast meant far greater familiarity with Magic Johnson. The results were notable. They found a 20% increase in AIDS diagnosis among heterosexual men in NBA metro areas. The effect lasted about 9 to 10 months and then faded, exactly what you would expect from an information shock that accelerated testing among people already infected but unaware. The cohort diagnosed right after the announcement were 7% more likely to still be alive a decade later. This survival benefit was driven entirely by men diagnosed through formal blood tests, not those who are already visibly ill. These were men who walked into a clinic because Magic Johnson made them reconsider their risk. The effect was concentrated among Black and Hispanic men, consistent with research showing that celebrity health disclosures resonate most with demographically similar populations. The researchers estimated Johnson's announcement caused roughly 800 additional heterosexual men in NBA metro areas to discover their AIDS diagnosis. And since AIDS, not HIV, diagnoses were tracked, the true number who learned their status is almost certainly far larger. Johnson's announcement also reshaped sports policy. Despite retiring, he later returned for the 1992 All-Star Game and participated in the Olympic Dream Team in 1992, sparking debate about whether HIV-positive athletes could safely compete. These debates ultimately produced formal guidelines. Johnson's survival, now over 3 decades, remains one of the most visible demonstrations of what recognition in antiretroviral therapy can achieve. I'm going to discuss next key takeaways from the 2020 AMSSM statement about participation in athletics for individuals who have bloodborne pathogens. Moderate exercise is beneficial for HIV-positive athletes, improving physical fitness, immune function, and quality of life, while strenuous exercise should be avoided in those with advanced disease or CD4 counts below 200. For healthy, asymptomatic HIV-positive individuals, unrestricted exercise is acceptable. Moderate aerobic exercise, which they define as 20 minutes 3 times weekly, increases CD4 levels in asymptomatic patients and improves aerobic capacity, body composition, insulin sensitivity, and psychological well-being. Athletes with mild to moderate symptoms or CD4 counts below 200 should avoid strenuous, exhaustive exercise. Those with AIDS may remain active as tolerated, but should reduce or stop training during acute opportunistic infections. Intense exercise may impair the ability to mobilize neutrophils and natural killer cells in HIV-positive patients. The risk of HIV transmission during sports participation is extremely low, with no well-documented confirmed cases of transmission during athletic competition. The theoretical risk in contact sports like the NFL has been estimated at less than 1 per 85 million game contacts. Studies demonstrate that HIV-positive individuals can achieve fitness improvements comparable to HIV-negative controls. One study among active duty U.S. Air Force members with HIV showed preserved and even improved exercise performance post-diagnosis, with composite fitness scores actually increasing after HIV diagnosis. Both moderate and high-intensity training programs increase functional capacity without detrimental changes in immunologic variables. Universal testing for bloodborne pathogens is not recommended as a requirement for sports participation. There is one notable specific set of athletes who I want to talk specifically about. This is the combat sports exception. The Association of Ringside Physicians recommends that all combat sports athletes, this includes boxing and MMA, undergo serum-based testing for HIV, hepatitis B, and hepatitis C within 3 to 6 months of competition, given the high likelihood of blood exposures. Athletes with active HIV infection should be disqualified from these types of competitions where blood is common and allowed. Next up, practice questions. Question 1. A 28-year-old asymptomatic HIV-positive marathon runner with a CD4 count of 450 cells per millimeter squared on stable antiretroviral therapy asks about continuing competitive training. According to the American Medical Society for Sports Medicine guidelines, what is the most appropriate recommendation? A. Discontinue all competitive running immediately. B. Limit exercise to low-intensity exercise only. C. Unrestricted exercise participation is acceptable. D. Restrict training to non-contact sports only. E. Require monthly CD4 monitoring before each competition. The answer is C. The AMSSM recommends unrestricted exercise for healthy asymptomatic HIV-positive individuals. Question 2. An HIV-positive collegiate wrestler with a CD4 count of 180 presents for clearance. He reports mild fatigue and occasional night sweats, but no acute illness. What exercise recommendation is most appropriate? A. Full clearance for unrestricted wrestling. B. Avoid strenuous, exhaustive exercise. C. Participation only in non-contact sports. D. Complete exercise restriction until his CD4 count is greater than 200. And E. Clearance contingent on negative viral load. The answer is B. HIV positive athletes with mild to moderate symptoms or CD4 counts less than 200 should avoid strenuous, exhaustive exercise. The combination of low CD4 count and mild symptoms warrants this exercise modification. Question 3. What is the estimated theoretical risk of HIV transmission per game contact in the National Football League? A, 1 per million, B, 1 per 10 million, C, 1 per 85 million, D, 1 per 500 million, and E, no calculable risk exists. The answer is C. The theoretical risk has been estimated at less than 1 per 85 million game contacts, or less than 1 transmission in 58 seasons. This estimate is likely overinflated as it extrapolates from healthcare needle stick data. Question 4. A 32-year-old HIV-positive triathlete on combination antiretroviral therapy asks about the benefits of moderate aerobic exercise. Which of the following outcomes has been demonstrated in HIV-positive individuals performing 20 minutes of aerobic exercise 3 times weekly? A, decreased CD4 counts. B, increased viral load. C, improved CD4 levels in asymptomatic patients. D, impaired insulin sensitivity. And E, decreased quality of life. The answer is C. Moderate aerobic exercise increases CD4 levels in asymptomatic HIV-positive patients and improves aerobic capacity, body composition, insulin sensitivity, and psychological well-being. Question 5. According to current evidence, how many well-documented confirmed cases of HIV transmission have occurred during athletic competition? A, none. B, 1 to 5 cases. C, 6 to 10 cases. D, 11 to 20 cases. E, more than 20 cases. The answer is A. There are no well-documented confirmed reports of HIV transmission during athletic participation. One case report from Italy describing a possible transmission in recreational soccer could not exclude non-athletic risk factors and remains unconfirmed. Question 6. An HIV-positive boxer with AIDS and a CD4 count of 150 is recovering from a recent bout of pneumocystis pneumonia. He wants to return to training. What is the most appropriate recommendation regarding exercise intensity during his acute opportunistic infection? A, immediate return to full training intensity. B, moderate intensity training only. C, reduce or stop training during acute illness. D, low intensity resistance training only. E, aerobic exercise only without resistance training. The answer is C. Athletes with AIDS should reduce or stop training during acute opportunistic illness. While they may remain active as directed by symptomatology when stable, acute infection requires exercise modification or cessation temporarily. Thank you.